Thank you so much. I really appreciate this opportunity. I'm a general pediatrician, so getting to come to an oncology conference like this is really a pleasure. When Dr. Barrett was talking, it clicked why I was invited at this point for this opportunity. It also was an opportunity to meet, I'm embarrassed to say, one of Montefiore's leaders and your president-elect, Dr. Hopkins. We work in the same town, but we had to come to Minneapolis together to meet in person, so it was really a great opportunity. So I'm going to talk about my experience. So I'm a general pediatrician. I see patients about half a day a week, so there are certain families that put up with that, and I get to work with them in the Bronx. But I spend most of my time actually trying to figure out how do we integrate community expertise. And Dr. Barrett had this great line of, we often look at our community and we see all the gaps, we see all the deficits, but there are a lot of assets. There's a lot of expertise. And so that has been my mission the past 20 years, starting in West Africa and now turning to more domestic focus. So I want to start with a story. This is my friend Rose, and I'm telling you her story with her permission. She is the type of patient that requires a new approach to healthcare delivery. When I met her in 2003, she was 23 years old. We were the same age. She had been diagnosed with HIV. She had lost a daughter to HIV. That's how she found out she was HIV positive. Her husband died. Following her husband's death, she was kicked out of her house by his parents, and she was living alone with her family. In 2003, in West Africa, there was, in the part of the country where Rose lived, there was not access to antiretroviral therapy. So an HIV diagnosis was a death sentence. And we went to visit her. I went with a community health worker. That little line that you see is not the line by my eyes. It's not some kind of artistic fading of my face. It's actually an IV line. So we were providing treatment to her in her home because she didn't feel safe in the hospital. We're going to come back to Rose and why that health system in Togo was failing her, and it's an opportunity to learn what we could do better. So what is that opportunity? So you're all here today because you're talking about innovation, you're learning from colleagues about what's new. We saw these wonderful awards, these innovator awards. And we're going to learn a lot. You're learning a lot about what you do in terms of healthcare delivery. I would argue that the sweet spot in optimizing health outcomes for communities lies between that intersection of healthcare delivery, learning, you can call it research, and community, the kind of community engagement that Dr. Barrett referenced. I'm going to posit that one opportunity to bring community expertise into our health systems is through the integration of community health workers. And that's my agenda here today. So I'm going to do a very quick CHW 101s. I know many of you, I spoke with a few of you yesterday evening, you already have community health workers at your health system. For those that don't, I'm going to give just a short course in what is a community health worker? What is the evidence for community health workers? And then I'm going to go over 3 cases that I've lived through. I'm going to try in 40 minutes to go over 20 years of experience. Starting in West Africa, focused on HIV/AIDS, turning to a program that was focused on maternal and child health, also in West Africa and in Guinea. And then ending with what we're doing in the Bronx around community health workers. And I'm going to show how what they're doing outside of the US is informing what we're doing in New York City. And I'm going to close with some lessons learned. Okay, so what is a community health worker? For those that remember Cliff Notes, okay, yeah, I got through college with those. Was not as strong in my English literature class as maybe I should have been. So a community health worker they go by different titles, but the essential characteristic of a community health worker is they are someone with expertise in the community that you're serving. These are not the well-meaning, well-intentioned pre-med students who are volunteering at your health systems, who are trying to get into medical school. There's a place for them. These are people who have walked through the shoes of the patients that you're serving. They have expertise that you may not have on your clinical team. That's what a community health worker is. And because they have this expertise, because they have this trusted relationship, they bring value to your health system in the way you deliver care. And I'm going to show you how they do that. Community health workers are not a new concept. We've had community health workers for over 100 years throughout the world. It's relatively new to the United States, but they're all over the world in some very high-performing health systems, and especially if you look at what is spent per GDP, places like Costa Rica, Ethiopia, Brazil. They have used this workforce to really enhance health outcomes, moving upstream on some level. In 2018, the World Health Organization, recognizing the importance of this workforce, actually put out guidelines. This was based on an extensive literature review. There were committees I was involved in, and some of the external committees around what are the key elements that we need for high-performing community health worker programs. An organization that I work with called the Community Health Impact Coalition based in New York City represents 20 different nonprofit organizations spanning 40 different countries. We put together something called the Updated Program Functionality Matrix, horrible name, with UNICEF and USAID to try to take those guidelines and put those guidelines in a language and in a context that program administrators can utilize on the ground. So what's the evidence for community health workers in the United States? Well, we have a lot. We have ROIs. Shreya Kangovi, who's based at the University of Pennsylvania, has published extensively on this in the adult literature. This is a review paper. I'm just citing 16 randomized control trials, 12 reporting utilization outcomes, including significant reduction in ED visits, hospitalizations, and urgent care. Those are the health outcomes that we measure. So then the question becomes, why would a community health worker bring this kind of value to our health system? So this is one mechanism that's been posited. So that this idea that you have somebody who is a trusted member of the community helping to sort of translate and build that trust with your patients translates into better care. Simple mechanism. Simple but not. Okay, that's your one-on-one course. You all passed. I'm going to get into the cases. So we have Rose again. So I'm going to come back to Rose. Rose she's holding her niece, whose name is Deborah. Deborah was the first baby that was born in northern Togo that went through a prevention to mother-to-child transmission program. She's HIV negative. She's one of hundreds of babies that have been born in northern Togo, all of them HIV negative. So why am I talking about Togo? How did I get there? If you Google Togo, it's not the sandwich shop. That's the first thing that usually comes up. After graduate school, I went into the Peace Corps, and I was invited to go to this small country in West Africa. It's sandwiched right between Ghana and Benin. And I met this organization, and they're called Association Espoir pour Demain. So for the French speakers out there, you know this means hope for tomorrow. So this group of people, they had all done what the government had told them to do. They got tested for HIV, and the test came back positive. And their question was, well, what next? What do we do now? There was not a treatment option in Togo at that point in 2003. There were medications for HIV, but they were not getting to the community that needed them the most. And so this group self-organized, and they decided, I want to bring a treatment option and introduce it into northern Togo. And I said, okay, sign me up. How can I be involved? And what came from that is the formation of an organization called Integrate Health, which just celebrated 20 years of doing work in West Africa this past Monday. So I want to talk a little bit about the problem that this group was trying to face. So many of you are aware of the HIV/AIDS pandemic in sub-Saharan Africa, know that most of the cases initially were concentrated in the southern countries of sub-Saharan Africa. And West Africa was this unique place where the prevalence was relatively low compared to their southern neighbors. And as a result, it was largely neglected in terms of funding and attention. So what happened was you had 20% of all new infections in sub-Saharan Africa were in West and Central Africa. 27% of all deaths were there, and 45% of children born with HIV were based there. So when I started talking to this organization about introducing a treatment option, the question was, well, how do we do this? And I had just finished graduate school in public health. I was qualified basically to do very little except like run regression analyses. And so I reached out to people who knew what they were doing. And I started working with two organizations, John Snow through Lisa Hirschhorn, and a group called Partners in Health, also based in Boston, that was run by the late Paul Farmer. And what we did is we took these evidence-based guidelines, we mentioned them to community members, and we put together what we thought would be an effective model, adapting it to the local context. So things like we wanted to have a program to prevent mother-to-child transmission, we wanted pharmacy and nutrition support, we wanted to have education on antiretroviral therapy, we wanted support for the many orphans that we had that the organization had identified. But at the foundation of all of this was this idea of having community members part of the care delivery chain. And not just any community members, but we wanted to have people who actually had HIV serve as those community members. So when they went to make home visits to people who were just starting antiretroviral therapy in 2005, and that person was saying, it's really hard to take a medication every day, they can say, yeah, I know, I get it. It's something you can't train. So what did we do in the first decade with this community-directed HIV/AIDS initiative in Togo? Well, we started in 2004, relatively modest amount of individuals living with HIV, engaged in care. By 2014, we had over 1,800. We started the first individuals, 3 individuals on antiretroviral therapy in 2004. Rose was one of those individuals. We propped up 5 new health centers that were adjacent to some of the local hospitals. And we did this based on the feedback that we got from the community members who said, I don't feel comfortable going to the hospital. They don't treat me with the kind of respect that I want to be treated. And what I'm most proud of is our entire staff at that point in country, they were all Togolese. So this was not a US-based intervention where we were coming in and telling them what to do. Okay, so those are some process measures. Well, what was our impact? So I'm not going to go into too much detail about this, but this was our initial survival assessment. So what we tried to do was figure out, of the people that started antiretroviral care with us, how many of them actually lived. And so the result was 7, our mortality rate was 7 per 4 deaths per year, which for those in the HIV world, this may mean something too. This is a very low number and much better than some of our peers in the same region. So about this time, this was 2007, 2008, I was just finishing medical school, and I was going back and forth. So I had spent 3 years in Togo. I lived there for 3 years, came back. I decided I wanted to go to medical school, started medical school in Seattle, and I was going back and forth at this time, and a very interesting thing happened in 2007. So one of my friends pulled me aside. I was making one of these routine meetings. He said, hey, Kevin, I have 4 kids now. They're all HIV negative. None of them can come to this clinic. We got to do something else. We got to do something better. And so we started talking with the government in Togo and said, hey, we have a model. The foundation is this community health worker program. Let's look at other sort of key areas within your health system where this could be applied and adapted. And this bore into the integrated primary care program. And when we looked at the gap in Togo at that time, we looked at where we can make the most difference and where were they having the hardest time. So the graph on your left shows the under 5 mortality rate. So this is the global measure of how a country is doing in terms of what is the probability that a child born today will live to see their 5th birthday. So one thing to point out about Togo, it's very high. Not only is it very high, they were regressing. So you can see that line when it goes from blue to green. So the green line are the lowest developed countries by the United Nations. They're making progress. They're bringing their under 5 mortality down. That wasn't happening in Togo. If you look at the leading causes of death, top 5, comparing 2005 to 2016, there was no change. Even though you had many countries that were transitioning into leading causes of death being more non-communicable diseases, this was not happening in Togo. So we had a gap. And again, we looked to the literature, who was doing this well. And we, with our community members, found and developed, this was an approach that was based on work that had been done in Mali, work that had been done in Rwanda. This idea of bringing community health workers, focusing on the clinical capacity of the most rural health centers, beefing up supply chain and infrastructure, and removing user fees. So we couldn't remove every barrier to care, but we could remove some of them. And our hypothesis was, if we improve quality of care and access, we would reduce mortality. This is the deal we made with the government. So we piloted this approach in 4 health centers, catchment population of about 25,000. And this is what we found. So over a 5-year period, we saw a decline of 30% in under 5 mortality in those catchment areas. Furthermore, when we looked deeper into the data, we tried to figure out, well, why? What was the reason? And one of the things that really came out, and this was published in our paper in Pediatrics, was that households reporting a visit to a community health worker in the last 12 months, before and after our intervention, went sky high. And when we did our qualitative assessments of what was happening, this is what the patients were reporting. This is what the community members were reporting, is I had somebody who was coming to check on me, who, if my child had a fever, I could reach out to. They lived just around the corner. So you had this connection to the health system through community members. When we showed this data to the government, they actually didn't believe us. So it was an interesting conversation because they didn't believe us, but at the same time they wanted us to expand the model, which we did in 2018. So we expanded the model to 23 new health centers, a catchment population of 100,000. We just finished the 5-year assessment. It's not published yet, but I'll just share. The impact measure is the same. So at 5x scale, we're still seeing a reduction in under 5 mortality. And again, we're seeing the key component of the intervention that's making a difference is this link between health system and community through a community health worker. Okay, so I've been talking about Togo for a while. I obviously have a very strong connection to Togo. I met my wife there. She is a New Yorker, so we are a New York family now. My younger son, who's 10, is a Yankees fan, which kills me because my family is from Boston. So we're actively working through that. But as I started looking at what are the things that Rebecca, so this is Rebecca, she's one of my colleagues, she works in rural Pindi. There are things that she does that are applicable to my colleague Janet, who's a community health worker in the Bronx. And so I pitched this idea to our leadership. Could we think about, again, adapting a community health worker model, but in the US context to a problem that their health system is facing? And that brings us to case 3. The Community Health Worker Institute at Montefiore Einstein. Many of you know, either as clinicians or administrators, that health is driven by more than just healthcare. I am not making the case that healthcare is not essential. It is absolutely required and also insufficient if we're talking about optimizing health outcomes. This has gained more attention in recent years. The National Academies of Medicine, Engineering, and Science actually put out a guide that our health system has adopted that goes over how to integrate social care into the delivery of healthcare. I would argue that the oncology field is way out ahead of this. You guys have been talking about this much longer than the rest of us have. So we're playing catch up a little bit. But the idea that there are things that we do at the patient level, there are things that we can do in terms of our health system, making adjustments, making alignments. But it all starts at the center with, you have to know what your patient's problems are. You have to be aware of what those things are. So at Montefiore, I've been part of a team that has led a health-related social needs screening initiative starting in 2018. So what our health system invested in is we put together a multidisciplinary committee. We spent a lot of time debating what is the perfect screener to assess health-related social needs, maybe a little bit too much time. But we landed on adapting the Health Leads toolkit. We chose 9 questions from that toolkit. So we ask about things like food insecurity, housing quality, housing insecurity. It is completely integrated within our electronic health record, and I'll explain why that's important in a second. We knew that if we wanted to ask clinical teams to screen for these health-related social needs, the screener had to be easy to interpret, it had to be short, and it had to be things that we could actually do something about. So this was not an academic exercise, even though my initial entree into this field started as a researcher. I have been doing some research grant with HRQ. So then we had to invest in, okay, when a patient expresses that they have a food insecurity issue, what are we doing? So we have 2 ways that we deal with that at Montefiore. We have a social service platform called Find Help. It's integrated within our electronic health record. Basically, it's like the Yelp for social services. You can quickly type in a patient's zip code, social need category, and it spits out a list of available resources. And the last part of that is we started integrating CHWs. And I'll get back to that in a second. So in our first 5 years of this initiative, Montefiore screened about 250,000. The updated number to this, because I just got data this past week, is as of October 1st, we've screened 300,000 unique patients. So the Bronx has a population of 1.5 million. So we've screened over 15% of the Bronx population. These screenings also include patients that are in our White Plains and some of our Westchester hospitals. Because the data is in our electronic health record, we know the social needs that are being endorsed by our patients. So this is just a snapshot of the 3,700 patients that we've identified with social needs, what they're telling us they have problems with. So food insecurity, housing quality, housing insecurity, those have been our top 3 social needs since we started screening. My team has been taking the data and trying to figure out, okay, we see these social needs. How are they impacting our bottom line? How are they impacting our health outcomes? We did an assessment in our primary care network. We looked at missed appointments. So missed appointments is just straight waste for our health system. We have our team there, they're ready to see a patient. They don't get to see that patient, so that patient doesn't get the care that they need. We usually can't find somebody to come in and take that slot, and we have waiting lists at some of our clinics. And we lose about $200 every time this happens. So we ran a regression analysis to try to figure out, well, what does it look like in terms of missed appointments when we compare patients that have social needs versus those that don't? And we handed that result to someone in our finance team, and they said, well, back of the envelope calculation, we lost about $17 million as pertains to patients that have social needs over that 18-month period. So then we tried to figure out, well, how do we boost screening of social needs? So we built all these tools, we put it into our electronic health record, and then what happened was a lot of clinics just didn't use it. And so we did this study to try to figure out, well, what were the things that really mattered the most? And what we found is that when we introduce a community health worker into a clinical team, screening rates go way up. And coming out of COVID, and many communities were affected, but New York City and particularly the Bronx was affected by COVID, there was this renewed interest we need to do a better job at taking care of these factors that we know are affecting our patients' ability to come in for care and to stay in the care. And so leadership supported the idea of creating, in 2021, the CHW Institute at Montefiore. We had had CHWs at Montefiore since the 1970s. Here's the problem that we had with them. We had small pilot programs that would stop at the end of the 3 or 5 year grant cycle. They were disparate, they were fragmented. We were not taking advantage of economies of scale. We had 10 different training programs, different scopes of work. And so we brought that all into a centralized structure that reported into the chief medical officer, who was our biggest sponsor, our biggest supporter, and one of my mentors. And we had a goal. So we had 2 goals. One is we wanted to optimize community health worker recruitment, integration, retention. But our second goal is we wanted to bring jobs to Bronx community members. As I said at the beginning, we knew that there was expertise and assets that we were not leveraging to the best of our ability in the Bronx community. They were coming into our clinics. And so we wanted to bring them into our health system and integrate them within our teams. So we started developing standardized workflows that involved the entire clinical team around screening, around what do we do when a patient says positive to this question versus this question. So we built in workflows. We adapted them based on the different sites. We made sure that the community health workers would document what they did with the patient in our electronic health record. This is a very important lesson that we learned from some of our previous community health worker programs where we contracted out to smaller CBOs. We'd refer out to these CBOs and we'd have no idea what happened with the patient. And what happened? The provider stopped referring. The professional development and the training of a community health worker is a big part of what we've invested in. So I talked about all the assets that these community members have, but the reality is also that this is often their first job. And so you have to invest in the team that can explain how our health system functions. I'm still learning myself some days, but integrating into a healthcare system that is fragmented and a healthcare system that says, well, you're internal medicine, you're pediatrics, you're OBGYN, it's very challenging. So we spend a lot of time. We have an institutional training around that. We have a partnership with our local community college, Hostos. So our CHWs actually go back to school. So we build out time during their day. They take courses at Hostos Community College around medical terminology, around public health. That leads to an accreditation through New York State's Department of Labor. It's the only accreditation that we have for community health workers in New York State. And it gives them 9 college credits towards an associate's degree. We also have training specific to our supervisors. So our supervisors are actually coaches. So we adapted a model that we learned that was initially developed in Rwanda called Mentoring and Enhanced Supervision for Healthcare. And we have our supervisors play the role of coach, the role of professional development, so that we are optimizing not only the work that our CHWs are doing, but where they're going after. So we have a saying at our institute, we do not want any lifelong CHWs. We want them to come in, we want them to be with us at least a couple years, and then we want them to move on to something else. So it's an investment in the community, and you need a staff to be able to handle that kind of turnover. And then we've built out, so one thing that we realized really early is that the social needs navigation landscape changes quite rapidly. And some of the best sources of information are actually community health workers. And so we actually built out a living guidebook, an intranet site for our CHWs to be able to share best practices in terms of resources and CBOs. And then we focused on data. So the biggest question I get around, well, you have CHWs, they're helping patients with health-related social needs. Well, how do you know you made any kind of impact? What kind of impact are you making on housing insecurity? So with CHWs, we actually developed effectiveness outcomes. So we look at two measures. One is, if we referred them to something, did they get that service? And then the second measure is, if you got that service, do you feel like we've made progress? We are deliberately subjective, and we only care about the perspective of the patient in front of us as answer. Because sometimes we define success as something very different than what a patient does. So getting somebody a 3-bedroom apartment in this neighborhood, our patients are very savvy. They know that we do not have that kind of power. Helping them fill out a housing application or connecting them with a friendly broker who can help them find an affordable house, that's helpful to them. And they've told us that. That's a successful referral. And so we measure that, and we've actually built out a separate database that tracks every interaction that we have with a patient so that we can know where are we doing a good job, where can we improve. And we're trying to leverage what we're learning through a natural design. So we have this, and this gets to the learning part of the 3 bubbles. But we're trying to figure out from the data and the outputs, are we making a difference? So we have patients coming into our health system. Some of them screen positive for social needs, some of them screen negative. And so we looked at, and I showed some of these papers, well, what does that mean in terms of key health outcomes? What's the difference? We know that patients who have health-related social needs, they miss more appointments. They cost, on average, our health system about $1,500. So that paper just got published this last week, so it didn't make it into the slide set. Now we're starting to look at when a patient who has a social need gets exposed to a CHW, what does it look like after? So we've seen with pediatric patients, for example, families that had a social need that work with a CHW, their missed appointment rate goes down by 20%. And we're looking at that over time. We help about 7,000 or 8,000 families a year right now. We'll be closer to about 10,000 in 2025. Part of the Institute's role is trying to disseminate some of the things we're learning, the good, the bad, and the ugly. And offline, I'm happy to tell you all the things that are not working well within our program. But we're trying to look at the data and try to figure out how do we do this. And again, I mentioned that I feel very strongly that there's innovation, and Dr. Barrett alluded to this as well. There is innovation happening in unique places. And so last year I actually brought the Bronx team to Togo to see in action what a high-performing CHW program looks like. And it was amazing to see the discussion on the kinds of things which I would not at first glance say, oh yeah, I see how that connects to what we're doing in Togo, but they saw it. And I'm a part of an organization funded by the Robert Wood Johnson Foundation. It's based at the University of Maryland. It's called the Global Health Learning for Health Equity Group. We've been publishing some papers on different groups in the US that are looking at innovative models outside the US and trying to adapt them. So I want to bring it together. So what are the lessons that our team has learned the past 20 years, trying to find that sweet spot between community, healthcare delivery, and learning? So as I tried to mention, there's an opportunity to leverage community expertise, and CHWs are just one way to do it. I did not mean to pretend that this is the only way we bring community expertise into our health systems, but I think it's one way, and I think it's an effective way. It is a promising approach, but it requires investment. So for any of you that I have convinced on some level that this is an approach you want to take, it is not simply a matter of recruiting community members and then plopping them down in the clinic and then something happens. You really have to invest in training. You have to invest in thinking about their scope of work. You have to invest in their professional development. And you need staff and need dollars to do that. And last, I would argue that investing in CHWs, it has benefits way beyond healthcare. When we talk about, and many of us work at places where our institution is an anchor institution in the community. So the idea that we are actively investing in the upward mobility of our community members through community health workers, I think it's a real opportunity. So let's get back to Rose. I already mentioned she was one of the first 3 people to start on antiretroviral therapy in 2004. She did very well. A year later, she became a community health worker herself. So she became one of those people that is visiting other individuals who are starting on antiretroviral therapy. She got promoted a couple years after that, so she became one of the pharmacy managers of our antiretroviral stock at the clinic. This is her in 2013. She's holding my son. This is not the Yankees fan, by the way. He doesn't get a photo. She's holding my son, who's now 13. She today is the director of pharmacy services for the organization. She's doing very well. She's mentored countless community health workers. And I think it just goes to show there's how community health workers can improve our healthcare delivery. It's also a way to give back to the communities that we work with. I obviously am a community health worker Kool-Aid drinker. And I hope that I can help. I've inspired you to maybe join our team. We have a secret handshake and everything. And I very much thank you for this opportunity to share our experiences. And I'm happy, if there's time for questions, to take any questions. Thank you. Yeah.
Thank you so much. That was an amazing presentation. My question is a little bit in the weeds.
Great.
I'm curious if you can share with me sort of if you have an average of number of visits for
Yep.
these interventions
Yep.
and what provided the outcome, and then one more. Where they're doing the visits. Is
Yep.
it in the clinic in their home?
Yep. Great question. So for our Bronx-based community health workers, we have 2 types. We have a generalist CHW. They just focus on social needs navigation, and we have a specialist. The specialist is often integrated within a specific service line. So with our Monica Einstein Cancer Center, we have 3 CHWs that are working with our cancer center. A generalist CHW on average sees about 400 families a year. That's the ratio that we found over time. A more specialized CHW, so CHWs that are doing more than just helping with the social service navigation. They're maybe doing some more healthcare navigation services, education, other kinds of activities. They usually see between 150 to 200 families a year. If you were going to ask me a follow-up question, you'd ask, well, how are we funding this? And it's been interesting because New York State Medicaid just introduced a funding reimbursement opportunity for CHWs. It is nowhere near, the rate is nowhere near what it will take to make this a neutral program. And so you just need to know that. So we have a braided funding model. We have institutional support. We have reimbursement support. And then we're also dependent on philanthropy.
Great. And just where do they see the patient?
Yes, sorry. So the majority of our CHWs are actually physically sitting in our clinics. And the reason why we made that decision is often the clinical teams feel more comfortable when they actually know who they're referring out to. And the CHWs themselves get a better sense of clinical workflows when they're actually physically sitting there. We do have on rare occasions CHWs that will go out into the community and they'll accompany a patient to an HRA visit or interview. But we have found that that's been very hard because it usually is like an all-day occurrence. And so it's been challenging to coordinate those kinds of services. We have done models like that in the past, but we're really focused on keeping them within our clinical space and bringing that expertise into the clinical team. And they're going to morning huddles, they're going to all of our meetings, and so they're just bringing another perspective that we have found to be very valuable. Yeah. Great questions.
Thank you. Very inspiring talk. I have spent, I'm not a nurse navigator or a care manager, but I've spent a lot of time working with navigators and CHWs in the community. And one thing that I've seen, whether it's ED discharge nurses to chronic disease care managers to navigators for oncology and also CHWs, is that there is a sort of chronic underinvestment in the number of people and also in the resources to support those people. So sometimes we start these programs and there's one nurse, there's one navigator, and they're totally overwhelmed. And then they have Excel spreadsheets, they have sticky notes all over their computers, and it's kind of disheartening to have seen this now for over 20 years. And how, I guess, do you think this is happening, and how can we make a better case for more investment?
Yeah. Great question. I do not know that I have a solution, to be honest. I mean, this has been part of our experience at Montefiore. I mean, we've had CHWs for since the 1970s. None of those programs have scaled, and none of them have sustained themselves. And our argument when we built our centralized structure is, to your point, if you don't put this person in an environment where they're going to be supported, they're going to burn out and they're going to quit, period. Dealing with patients that have these very complicated social needs that do not get fixed by writing a prescription for something is very challenging work. And so I think if you want to make the investment in that supporting staff, you will have a higher performing workforce. And if you don't, I think you run the risk of just burning folks out, or somebody goes on leave, and you won't have the coverage and you won't have the sort of the performance that you need. I've seen this internationally as well on CHW's programs in East Africa, in Australia, in New Zealand. They do the same. Some of these programs do the same thing, where they just underinvest in the support staff that's required to really prop up this workforce to do a good job. So I couldn't agree more with your comment, and working on a solution as well. Yeah. Dr. Barnett. Oh.
I didn't realize if we're at time, we're at time. Right. So Terry Keys with the University of Kentucky Markey Cancer Center, and what a fine talk, and particularly when we're talking about in my state we have so many rural population. Not to mention that they're in Appalachia, Kentucky, where there are all kinds of reasons why they can't get to health care.
Yep.
So my question is, if I'm remembering your figures correctly, you said that there was $17 million in lost revenue from missed appointments, but then you dropped that rate by 20%. Now, if I'm looking at that, and
it's a lot of money.
My math, right? That's $3.4 million in
Yes.
savings, right? And so I'm wondering, is that one of the things, do you ever get to go back and say, yes, but look, we've saved you $3.4 million, and that's reinvesting into a problem that we can drop that even lower. So I'm wondering if that's part of your calculus, or you're really looking at whether or not you have the grant money, or you have the foundation money, or your organization's money to actually move you ahead.
Yes, that is 100% our strategy. I have made that statement, not exactly how you worded it, back to our financial team, because it doesn't just stop. So that is the sort of lowest hanging fruit in terms of the costs that we're recuperating. There's also things like our patient satisfaction and our star ratings. So we're reporting in our qualitative work that our patients just like coming to our clinics more when they have this kind of interaction. So that has been part of the calculus in terms of how to scale and sustain this workforce. So we're just kind of at the beginning of this new iteration. We have We'll have 45 CHWs in our health system by the end of this calendar year. We need about 100. That's our estimate right now. And so those are the kinds, and that's what we're using the data for, is to try to figure out where are we saving money, where are we improving health outcomes. We have some work that we're doing actually in the Montefiore Einstein Cancer Center around treatment delays. So we're finding that we're finding that patients who have a social need are delayed in terms of getting the diagnosis. They're also delayed once they're diagnosed getting into treatment. So we're working with one of my colleagues, Vika Smeta, on, well, if you insert a CHW into that problem, does that time get shorter? So those are the kinds of things that we're working on right now. Yeah, great question.
Thank you. This was a fantastic talk, and I think there's so many pieces that we could apply to our own work. I'm a little curious about, and maybe you mentioned this and I missed it, so my apologies, but a lot of it sounds like it's the community health worker starts at the point of someone being diagnosed. Is that correct, or are there actually community health workers that are actually doing the front end of like education, outreach, and screening? And so if there are both, could you tell us how you differentiate them and how they connect and how they work within the system?
Sure.
Thanks.
So we have two types of CHWs. So the CHWs that are specialized CHWs, they actually work with, right now they're working with our Lupus Institute, our Adult Endocrine, Montefiore Einstein Cancer Center, and then we have a program called Healthy Steps. So it targets families with a child who are 0 to 5, who are at high risk. They score high on something called the Adverse Childhood Experience Score. Those CHWs, once the patient expresses that they would like to work with the CHW, they're working with them on a long-term basis. So that could be upwards, depending on the family, for up to a year. And they're working through, helping them with appointments, helping them sort of manage if there are any insurance issues. They're not sort of Medicaid enrollers themselves, but they work with some of our offices that help with that. So they're trying to find a way to sort of walk with the patient on many different levels. The other thing I want to mention is we are deliberately clinically agnostic with our CHWs, and the reason why we're like that is our experience has been when you just put a CHW in one clinical department, it's often frustrating for a patient or a family because not everybody goes to just that department. So mom is in internal medicine or OB, GYN, their kids are in pediatrics, and they're working with two different teams. Our CHWs are designed, they're in a centralized program, so that they can cross those silos of clinical departments. So that's one of the things that we've done deliberately with our programs. Great question.
Hi, I'm curious when you talked about the funding and you talked about New York State and the Medicaid funding. You guys are a really organized program relative to a lot of places that are out there. Have you looked into, or are you considering doing the CHI and PIN services reimbursement that Medicare came out with earlier this year? And if so, what's like success, or what's included in what you've reported so far?
Yes, we are actively working with billing and compliance around that. The Medicare opportunities are, in terms of the documentation required, is much more burdensome, and it's much more burdensome on a clinical team. And so we're trying to find ways with our partners and billing and compliance to sort of automate the kind of documentation that we would need to take advantage of those Medicare opportunities. It's been a challenge, to be totally honest. Even though, thank you for saying we're organized. It doesn't feel like that some days. But part of it is, and I'm not trying to throw our EHR under the bus, it's really not designed for community health workers. Some people would argue it's not designed for providers either on some level. But it's really not designed for the kind of work. So CHWs can't bill. So we have to find ways to sort of drop codes in automate certain processes and have certain kind of documentation. For example, Medicare requires that physician or the provider rather, or the CHW explain why health-related social need affects, the diagnosis is affected by a health-related social need. So in the definition, it's a health-related social need. You have to explain why it's a health-related social need. So as you can see, it's very frustrating for the clinical team. So we're trying to figure out ways to do that, but it's going to be a challenge.
Thank you very much. That really was a very inspiring talk. I live and work in Lagos, in Nigeria, so you can imagine, for me, I was thinking about how many things we could possibly put in place. 2 questions, and I might have gotten it wrong, but you're talking about the community health workers being in the clinic and people having to travel to them. In Togo, what happens to the people who can't get there?
Yep.
Right? That's the first thing. And the other thing is, obviously, this is all fantastically funded because you've been interested and have spent quite a lot of your time there. But has the government actually now switched to actually employing these CHW teams so that it's going to be sustainable for the longer term? Thank you.
Great questions. I should have explained. So the CHWs that are clinic-based are only the ones in the Bronx. So the CHWs in Togo, they spend very little time in the clinic, actually. And that's just, it's also a rural-urban difference where a lot of our CHWs are posted outside of 5 kilometers of a clinic per the national government policy. And your second point is, yes, to some extent. The government is starting to invest in this workforce. We are having the debate right now of what a living wage is for a CHW, and so trying to make the case that, if you underpay someone or if you ask someone who already doesn't have a full-time job to volunteer their time, well, you're going to get a certain quality of work. And so if you're really talking about the return on investment, the return on investment for CHWs internationally has been well documented. It's about 7 to 1. So it's a much bigger impact than what we've seen in the US. They're starting to have that conversation. Interestingly enough, Guinea, which is run by the military right now, they have been much more open to this idea of funding CHWs. I think they see it as an imperative in a way that they can improve some of their health outcomes. So it's been an easier conversation in Guinea than it has in Togo so far. Yeah. Thank you. Okay. Thank you so much for the time. I really appreciate it.